Bismillahirrahmanirrahim. Assalamu alaikum. A 44-year-old woman came to the emergency department due to worsening abdominal pain. 2 weeks ago, the patient underwent a laparoscopic hysterectomy and bilateral salpingo-oophorectomy for adenomyosis. Her post-operative course was unremarkable and the patient went home the day after the procedure. She was eating normally until 2 days ago when she began experiencing increasing nausea and abdominal cramping after meal. Now the patient has abdominal cramping every few minutes and has vomited her pain medication. Her last bowel movement was 3 days ago, and she has not passed flatus today. Water signs are within normal limit. BMI is 34 kg. The abdomen is distended and tympanic on percussion. There is abdominal tenderness to palpation, but no rebound or guarding. The skin is intact toward the abdominal incision, but the right side incision has underlying tender palpable mass. Bowel sound are hyperactive. Abdominal X-ray reveal multiple air fluid level within the small bowel and no air in the rectum. A nasogastric tube is placed. Which of the following is the best next step in management of this patient? So this patient is a 44-year-old woman. She came to the emergency department due to worsening abdominal pain. 2 days ago, she had a laparoscopic hysterectomy. 2 weeks ago, abdominal laparoscopic hysterectomy and bilateral salpingo-oophorectomy. After that, she began experiencing increasing nausea and abdominal cramping. She has vomited her pain medication. Her last bowel movements were 3 days ago. She had not passed flatus today. Abdomen is distended and tympanic on percussion. There is abdominal tenderness to palpation. Right sided incision has an underlying tender palpable mass, which is most definitely incisional hernia. Bowel sound are hyperactive and abdominal X-ray shows multiple air fluid level within the small bowel and no air in the rectum. A nasogastric tube is placed. So based on these hints, the diagnosis of this question is complete small bowel obstruction. And the management for complete small bowel obstruction is emergency laparotomy. So here the correct option is choice E, emergency laparotomy. Patient with a complete small bowel obstruction, for example obstipation, no air in the rectum, as this patient having on abdominal X-ray, require nasogastric tube insertion for gastric decompression plus emergency laparotomy due to high risk of life-threatening complication, for example bowel ischemia and perforation. Come to the incorrect one, abdominal ultrasound. So abdominal ultrasound is not required at this patient having complete small bowel obstruction on X-ray, which show that there is no rectal gas. It requires emergency laparotomy to not cause the complication. Choice B, barium enema. So barium enema is for the large bowel obstruction. This patient having small bowel obstruction, there is no, this intervention will not help in the small bowel obstruction. Choice Z, bowel rest and serial. So bowel rest and serial abdominal examination will not help in this patient, but will worsen this patient complication because this patient having complete small bowel obstruction. Choice D, digital fecal disinfection will also worsen this patient complication because digital fecal infection is for the large bowel to relieve the constipation. Choice F, small bowel follow through. So small bowel follow through rest and choice E, small bowel follow through are not needed in such patient with complete small bowel obstruction, and small bowel follow through will cause more danger to the patient and will cause complication. Thank you.